happy to talk COVID, talk medicine at any time, and to be amongst your fans. And I had never heard about you until you had invited Paul on, and I watched his talks with you, and I've seen other of your talks, and they're just brilliant. And your fans are brilliant. They're super smart, really engaged intellectually. They're curious. They ask good questions. It must be a pleasure to sit where you sit and be surrounded by such vibrant, I would say, intellectuals. It's really, I'm happy to chat. So hopefully I can teach people something, and then we can go and do some discussion and Q&A. Okay. So, yeah, so like you said, Dr. Bean, I have a few kind of, I'm going to call them like little soapbox topics on COVID that I really want to be able to share with people as I've, battled this disease this many months and really been a student along with Paul. And I really want to say that I wouldn't be anywhere in COVID without Paul. He really has led our group. He formed our group. He led our group. We try to keep up with him. I think for every 5 papers he reads, cover to cover, I read maybe 1 or 2. So we're always behind him. But I'll say one of the areas in which I think I led some really potent insights is into what is COVID-19 respiratory disease, right? And so here's my first slide, and I want to talk about it because I think there's a global and persistent and pervasive misunderstanding of actually what's wrong with the patients who are arriving in the hospital hypoxemic and short of breath. And the amount of times that I see x-ray reports and CAT scans and medical notes in all of the charts calling it a viral pneumonia. And it's not a viral pneumonia. In fact, very few of the autopsies show cytopathic effects of the virus. It's really an inflammatory reaction to the virus having been there and or an inflammatory reaction to the viral debris. The RNA apparently triggers this reaction. So what actually it is, it's actually an organizing pneumonia. And so this is a paper that I wrote with one of the top chest radiologists in the country, Dr. Jeff Caney of the University of Wisconsin. He's the chief of thoracic imaging there, and he's very highly published and very well known in chest radiology circles. And I came to him early on when I was in New York, and I called him one day because he and I were close. We'd worked together closely as a pulmonologist and a chest radiologist. And I said, Jeff, what would you say if I told you that I thought that everybody with COVID had organizing pneumonia? And he said, yeah, we already know that. We published that in March. And I said this to him in late April. And so I said, are you kidding me? He told me that they had published an expert panel paper in the Journal of Radiology in March. And I said, the clinicians never got the memo. Nobody understands that this is an organizing pneumonia. And so I want to talk about organizing pneumonia for a few minutes. If you go to the next slide. So organizing pneumonia, what I call OP, it's really the worst named disease ever. Nobody can understand what it is because everybody thinks it's a pneumonia, meaning an infection. And it's not an infection. An organizing pneumonia, it's really a pneumonitis. It's a pattern of inflammation or reaction to some sort of lung injury. Sometimes it's idiopathic, so we don't know the cause. You just find this pattern of inflammation in the lung, and it has very characteristic radiographic patterns. And when you don't know what causes, it's called COP, right? So cryptogenic organizing pneumonia. Or if you've been around as long as you and I have, you remember the term BOOP, right? The disease BOOP, which is bronchiolitis obliterans organizing pneumonia, right? So it's actually a fairly rare lung disease. Pulmonologists know it best. And I'm going to tell you, as a pulmonologist, even amongst pulmonologists, many of them don't really get a good feel for it because it's a kind of a weird disease. So what it is, it's a pattern of lung injury, and it's strange what happens. So what happens is all these fibroblasts and myofibroblasts fill the alveoli and the alveolar ducts. And I know the cool beans know what I'm talking about because they know their anatomy, they know their immunology. I've seen your talks, Dr. Bovine, and so I think that these are easy terms to understand. And they fill those ducts and alveoli, and then they kind of form like collagen, like granulation tissue, almost like a healing pattern. And the problem is, but they fill those places, and so it impairs gas exchange, right? Now, what people don't realize is just as common as the idiopathic or cryptogenic form is, there's a lot of things that cause it. And when you see it, when you can identify the cause, we call it secondary organizing pneumonia. And probably the most common cause of secondary organizing pneumonia is an organism. So viruses can cause it. In fact, in the prior pandemics, it was increasingly being recognized. So in SARS, in one paper, in one ICU, they had between 30 and 60% of the patients who they found on biopsy actually had organizing pneumonia. And that was in the first SARS pandemic. And then also there were reports from H1N1 and MERS. So these viral pandemics, we know it causes organizing pneumonia. In COVID, I find it's almost uniform. And so if you look at the autopsy series of patients who die of COVID, very rarely do you see actual cytopathic damage from the virus. It's all, it's actually, well, the autopsies actually show DAD, which is diffuse alveolar damage, which is really just the end result of all lung injury. So if you die of lung injury, it's always going to be DAD. So it's not very helpful when you find DAD on an autopsy because you don't know what that progression is. And what's interesting about COVID respiratory disease is exactly no one ever did an early lung biopsy. No one, everyone thought it was a viral pneumonia. Why would you do a biopsy? They were COVID positive, they were sick, they looked like everybody else. And so no one really actually proved that it's organizing pneumonia. So how do we know that it is? Well, a couple of reasons. Well, number one, it behaves like it clinically. You have these ground glass opacities, and they appear and they're characterized in a pattern that's very consistent with organizing pneumonia. It has a very unique archetypal pattern, and so almost all the CAT scans show this organizing pneumonia pattern. The other thing is, and this is how I first made the association, is that this phenomenon of silent hypoxemia, or what people call happy hypoxemia, which is these very low oxygen levels, but the patients look okay, they're not struggling to breathe that much. That's where it kind of clicked in my head. I said, they remind me of my organizing pneumonia patients. As I take care of a lot of patients who are, a lot of lung cancer drugs actually will cause organizing pneumonia. And some of those patients, when they get sick, they're in the hospital for weeks on high amounts of oxygen, but they look okay. They just need tons of oxygen. And I was like, that's what these guys look like. And so that's how I first made the association. So next slide. And so for those of you pathology geeks out there, this is what the airspace is when they fill. It looks like collagen. So it's collagen filling airspaces. Normally they should be open. There should be lumens in air. But these distal airspaces get filled with collagen-like material. Next slide. And I use this term palm to forehead, which is what that sort of anecdote that I just told you, which is that Jeff Caney, who was the lead author of the the lead author of this expert panel, they published in March, and in that position paper where they reviewed all the CAT scans coming out of Wuhan, they wrote the most common reported CT findings in COVID-19 patients are typical of an organizing pneumonia pattern of lung injury. And I tried to publish my paper starting in April. It took me 6 journals. They all rejected it outright. They all thought it was a hypothesis. In fact, one major journal, actually was Chest, it went through peer review, and the reviewer rejected my paper, telling me they would only publish the paper if I did a randomized controlled trial of corticosteroids in COVID and proved that it worked. And then they would publish my paper. And like 3 weeks later, the recovery trial came out, which showed that corticosteroids were life-saving. And this is also one of the reasons why I argued, in the Senate back in May that the world needed to use corticosteroids. And I was ridiculed then, just like I'm being ridiculed now. Next slide. And so, if you play this, if you look, there's these, gray areas and black areas. And when you look carefully at it, if you could just play it, just let it go back and forth. You'll see these really strange and very sharp demarcations between the black and the gray. And that is really highly suggestive of organizing pneumonia, these diffuse bilateral lower lobe and well-demarcated patterns of ground glass, right? So it's not consolidative where you can't see any of the lung markings. It's just this diffuse sort of ground glass picture. If you go to the next slide. And the thing is, there's only one treatment for organizing pneumonia. Well, I guess 2. One is remove the offending agent, right? So if it's a drug, and it's very common, it's secondary to a lung drug, it's really synonymous with drug-induced lung injury. So you remove the offending agent, and then you use corticosteroids. There's never been trials on OP with steroids. It's just what pulmonologists have done. And here's the things that I tried to argue in my paper, and I tried to tell the world, listen, this is a pandemic of organizing pneumonia. Number one, the mainstay of treatment should be corticosteroids. It took them a while to realize that. Now they realize it. But they are failing to really act on this insight, which is they're giving these very low doses of steroids. Even patients dying, crashing on ventilators, they're giving them like these anemic doses of dexamethasone, 6 milligrams of dexamethasone. It's a joke. I give 80-year-olds with COPD more steroids than that. And so they're using very low doses, whereas we know in fulminant cases of acute respiratory failure with organized pneumonia, case reports going back decades, you need to use pulse dose steroids. And if you don't know what that means, it means very high doses. Things like 125 milligrams of methylprednisolone every 6 hours or 250 every 6 hours, like a gram a day. And that's sort of my practice and has been for a while with the severe patients in the ICU. The second thing that I think the world, the healthcare systems are failing to recognize about disease is not only you need to hit them hard and high, but you need to go long. Organizing pneumonia is actually a smoldering illness. It takes weeks and sometimes months to recover. You need to do prolonged doses of steroids, and you really shouldn't stop until the patients are better. And I've been traumatized by watching my whole experience caring for these patients of people stopping steroids while these patients are still sick. Their x-rays are abnormal. They're still inflamed. They're still on high amounts of oxygen, and people are stopping steroids. You know, it just makes no sense if you understand what this disease is. And so I think people are recognizing now you need to use higher doses, and you really need, my practice is I do not taper until they start getting better, and I taper along with their disease. It's like Paul gives the best analogy. He says it's almost like using a vasopressor in a septic shock. What dose of vasopressor do you use? You use the dose that fixes the blood pressure, right? So if they need high doses, you give them high doses. And as they get better, you go down. And same thing with steroids and organizing pneumonia. And I don't start to taper off until they're off oxygen. And then I generally taper over 2 to 3 weeks because we're seeing patients get readmitted. The last time I was in the unit in Milwaukee, when I did a month there, both on my service and my partner service, we each had like 8 or 9 patients. 2 or 3 patients on our service had been discharged from the hospital, off oxygen and off steroids, and a week later they were back, terrible lungs, they landed on ventilators, and a couple of them died. And so they're dying of actually, I think, insufficient treatment and inadequate prolonged treatment. And so I really want to try to get that out there to the doctors that are listening. You got to go more aggressive with the steroids here. Next slide. And then I'll go a little bit faster. So this is from my paper. This was a crazy case. Actually, it was a physician. She was 37 years old, and she had been on heated high-flow nasal cannula, 100% oxygen. If you look at the CAT scan on the left, and you see these really sharply demarcated peripheral areas of ground glass, there's only one thing that does that. That's organizing pneumonia right there. That's slam dunk classic organizing pneumonia. And she was on 100% for 7 days, and finally they decided to pulse her. And they gave her a gram a day of methylprednisolone for 3 days, and she immediately started getting better. Oxygen levels reduced. And this was her after discharge, 1 week after discharge, showing a little bit of scarring and bronchiectasis, but largely much better and off oxygen. And so it just shows you that this disease is quite steroid responsive. What's the interesting thing about this disease is nobody really knows why it's steroid responsive, like why these fibroblasts and myofibroblasts and collagen, why this dissipates with steroids. It's a little weird, but it does. Okay, next slide. And so this is, I'm just going to belabor my point. If you look at the randomized controlled trials, which have used the different corticosteroids, and if you look at the column to the right, it's called number needed to treat. If you guys know how to calculate a number needed to treat, it's really the difference. So if you look at a mortality difference, so if you look at that first slide, this was a paper from Iran where they gave 250 milligrams of methylprednisolone for 3 days. So this is pretty high doses. And they noticed that in the control group, it was 5.9%. In the treatment group, it was 5.9%, whereas 42% in the treatment group. In the control group. And so you saw this massive reduction in mortality to the extent that the number needed to treat, which is that metric that we use to show how powerful a therapy is, that means for every 2.7 people you do that to, you'll save 1 life. If you guys know what the number needed to treat is for defibrillating someone in VFib, it's actually 2.5. So using that dose in this disease in that trial, it was like you defibrillated someone out of VFib. And so look at the green boxes of number needed to treat when you're using methylprednisolone. Again, some of this is dose driven. I think also some of it is drug driven. I think we as a group strongly believe, and I'm sure Paul has talked to you about this, Dr. Mobeen, that methylprednisolone is superior to dexamethasone. If you look at this, the number needed to treat, 2.7, 6.2, 7.8. Then in yellow, look at dexamethasone in that ridiculous recovery trial where they gave 6 milligrams of dexamethasone. You would need to treat almost 20 patients to save a life in this Codex trial. And then here, if you're on oxygen, you need to treat 30 patients to save a life. And so it's really not very effective. So you just need higher doses, and we believe that the preferred drug is methylprednisolone. So this is just my slide screaming at the world, you're not being aggressive enough with this disease. I think too many people are dying from undertreatment. Next slide. And then this is just in the last couple of weeks. Finally, we had head-to-head trials. So this is the first head-to-head trials that I've seen. One of them, 86 patients in Shiraz, Iran. They did triple-blinded randomized controlled trial. They compared 2 mg per kg of methylpred versus 6 milligrams. Now, does that mean methylpred is superior or is the dose superior? I don't care. Look at the difference. The difference in survival. If you got 2 mg per kg of methylpred, you had mortality rate of 18%. It was more than doubled if you were on this anemic dose of 6 milligrams of dexamethasone. I tell you, it's just traumatizing when almost every hospital in this country has the protocol of 6 milligrams of dexamethasone. Nobody wants to think outside the box. Everybody just wants to follow the one trial without using clinical reasoning, and I just can't stand it. So, and then similarly, another one from Los Angeles just came up on a preprint where they compared patients who got 1 mg per kg versus dexamethasone doses, and they found that mortality was 16% in methylpred and 26% in that dexamethasone. So basically, my point is the best available evidence tells you go higher and go methylpred when you're treating this disease in the hospital. Next slide. And then, then we'll transition. We'll have a little bit of fun here. I can talk about my newest and favorite topic is ivermectin, right? So my man Soybean was on, I think it was last week or 2 weeks ago, right, Dr. Mobeen? And now I'm taking the name Poppy Bean. That's what I'm called at home. I'm called Poppy by my daughters. I figured I'd bring you guys some update because I got to tell you, every day of my life is something new happening in ivermectin. It's really a crazy and exciting time, and it's an honor to be at the head of it because it really is the cure for COVID, and the more and more that it's being recognized, the more and more satisfying it is to see. Well, it's equally satisfying and distressing. For everyone who doesn't recognize it, it's distressing. But anyways, let's go over some things. So next slide. Yeah, I gave a talk a couple weeks ago on long-haul COVID and ivermectin because the emerging evidence is showing that ivermectin is a really key treatment. Now, I don't want to go over long-haul COVID because Dr. Mobeen, you just did an episode of long-haul COVID. Am I correct? He's frozen, but I know.
So,
yeah.
There is a echo, that is why I was on a mute. So this whole week we're talking about the long haul.
But tell me, did you talk about ivermectin in long haul?
Yes.
You did.
But I would love to have your thought as well, because we still are trying to figure out the dosage, the frequency, and then the mechanism. So
perfect.
Your thoughts are very welcome.
All right, I'm just going to go quickly over some of the slides. We'll just go to the treatment and the anecdotes. So I know you guys have covered it. Everyone, even newspapers, lay people are getting a sense of what long haul is, right? So go to the next slide. It's these persistent symptoms. And you know what I got to tell you, as miserable as I feel for the long haulers of COVID, I actually feel that all of the patients in history who've had this syndrome from other viruses and other infections, because it's not uncommon. EBV causes this, right? Mono, even patients with Lyme talk about this chronic Lyme syndrome. So other infections have caused it. And many patients are distressed because physicians don't listen to them. And you know why? There's very few objective signs. It's all a constellation of symptoms. And so physicians are unsatisfied. There's no good treatments. And so everyone gets frustrated with the plight of the long hauler. And this was from a patient. And I just thought it was a really poignant sentence where they said, I felt like no one was taking me seriously before. And because there was no historical medical evidence of COVID long haul, I just didn't feel like I had a voice that people would listen to. And I think that has been said by many, many patients in the history of medicine who felt the sequelae of these, post-viral syndromes. Next slide. And so, it's very common. You can just go to the next slide, and I'll just go over. Right, we know the syndrome, right? It's a lot of these. I wouldn't say non-specific, but it's just hard to pin down, right? There's no signs of them. I mean, you say you have chills, you say you're tired. I can't measure that, right? Sometimes you'll have persistent fevers, dry cough, mild headache. That brain fog is so non-specific, right? People just feel like they're memory shot. They can't concentrate. They can't focus. And the saddest thing is that many people are actually have such a severe constellation of these, they're disabled. They can't go back to work. I'm in constant communication with actually someone from Paul's hometown, or where Paul lives, who's reached out to us, and he's a young man. He's, I think, in his early 30s, and he's essentially disabled, and he was very healthy beforehand. He's very frustrated because he just can't do nearly what he could do since he got COVID. So it's really a sad thing. Next slide. And we'll just go to the next slide. That's just from a survey. You guys get the symptoms. And so, the question is, does ivermectin have a role? And so if you guys have talked about it, so this is what I know. And I got to talk to Dr. Aguirre Chang. So down at the bottom, he's like probably the only report that I could find where actually someone published, and I would say this is on a preprint. It's not peer reviewed, but he put on a preprint his experience, carefully detailing what he did with 33 patients who had symptoms present for more than 4 weeks. And so what he did is he did 0.2 mg per kg daily dose for 2 days. And he said that after 2 days, almost all of them, 88%, total improvement, everything resolved, which I find truly remarkable, even for a case series. I think those patients are they're functioning as their own controls, right? If you have symptoms for 4 weeks and you take ivermectin for 2 days, and 2 days later you feel really better, I don't know that you need a randomized control group there. I think you can do a pre-post study on that one, and if you're a patient, you'll swear by it. And what's interesting is, since there was a few that didn't report total improvement, what he did, just saying, this is his protocol, is he doubled the dose and he went for 2 more days, and he actually picked off a few more patients. So almost all of his patients reported total resolution of their persistent symptoms. So that's one way to approach it. So next slide. Then I got to talk to him, and he actually posted this not too long ago. And so he and I actually, I found him on LinkedIn. Obviously a really guy very, very interested in long haul. I think he's probably the leader. I'm looking forward to more of his publications, and I hope he does more detailed reports and or trials. But his new protocol, he calls it a test. I guess he wants to it's a diagnosis and a treatment. I like those kind of things, right? So basically, he does this test to find out, is this long haul COVID? And so this is now quite different, if you'll see, right? So 0.2 to 0.3 mg per kg twice a day for 5 days. He does aspirin. What I couldn't fully understand is he does aspirin for 3 days, then adds the ivermectin. Clearly, he's treating inflammation here. In his writings, he is of the impression that this is persistent viral presence and viral replication. I actually don't think that's the case. I don't think ivermectin is acting as in its antiviral properties here. I think it's solely relying on its anti-inflammatory properties. But we can argue about that another time. As long as the patients get better, it's all good. And what he said is that he's found that his inexperience treating, and he's treated several hundred patients now, that the symptoms that respond the best are the sort of ear, nose, and throat, anosmia, nasal congestion, tachycardia, chest pains, night sweats, and then even the brain stuff, right? And so he says that if after 5 days of this combo, if symptoms improve by 40%, then he continues both until everything is resolved. So you have to show a response. And if you do, he pushes on, and I guess he's aggressive until you're better. And he says in about 300 patients treated, he says about 75 to 85% have responded. The ones that are most difficult he says, are the muscular or chronic fatigue. And there he's got a little cocktail which he uses, more variable. So that's a little less definitive what to do with those folks. And I think we need to learn more about them. So next slide. So those are two different protocols. Now, Fred Wagschel, who's actually part of our alliance, he helped. He was with us since the beginning when we first formed. His wife is on our PR team, and she's helped lead us throughout. And he's a pulmonologist, and he's been using ivermectin along with us when we discovered his efficacy. And now he's getting referrals, so people are seeking him out with long COVID. And not only is he saying it's the real deal in acute COVID, but now when he's getting these referrals with the long haulers, he's giving ivermectin 0.2 mg per kg. He does it daily for 5 to 7 days. And he says most report that in 3 to 5 days they're significantly better. And I didn't write it here, but just like Dr. Aguirre Chang in Peru, he says that about 75 to 80% of his patients respond when he uses this protocol. So there's a number of protocols that I gave you in the cool beans, Dr. Mobeen. Okay. Did you go over any of these things? Did you go over Aguirre Chang's papers, Dr. Mobeen, when you did?
No, we have not gone over these papers yet.
Okay, good.
So thank you very much that you are going through them.
Great. Okay, and then next slide. And so this is just, these two are just kind of anecdotes. I'm happy to share the slides later, or people can watch them, but they're just interesting. They're just really chronic and terrible symptoms that patients had, and then they took ivermectin. And again, this is one of those historical controls. I'm sorry, but when you have symptoms for up to 9 months, and then you decide to take ivermectin, and on day 1 you suddenly improved, you got two possibilities there. Number one, it's the most powerful placebo effect ever known to man, which is great. Take ivermectin, let it work as a placebo. Let it be fake news, okay? Or it's actually doing something. And this woman wrote to us. She just said that her fatigue faded into the background. It was so special. After the 3rd day, I was healed. I was so taken aback. I had to process whether this was actually the case. But then I could walk my dog, which was just not possible before. And if you go to the prior slide, Dr. Momi, it's similar, or no, I'm sorry, the next slide, after Mitzi. Same thing is that this woman wrote to us saying that she just, started taking ivermectin. Her diarrhea, which had been chronic for a long period, got better. The fatigue started to go away. The cough got better. And she was just so moved that she wrote to us this really moving testimonial. I gave her the name Karen. I don't know why, because actually I didn't get her name. But she said, "I will be grateful forever for ivermectin. It gave me my life back. And I am once again the energetic 77-year-old woman who once ran circles around her husband and her children." I got to tell you, I mean, as a physician, I've had a lot of satisfying experiences, but this takes the cake. This is really good stuff. So let's keep going. And then this is just two colleagues, Dr. Osgood. He treated an old research mentor of his who just said he got really better. One of our supporters also found that the guy got off oxygen very quickly after ivermectin, after 3 doses. And so we're seeing just more and more, again, anecdotal reports, but so compelling, really, really compelling. And so, again, ivermectin is one of the safest drugs known in the history of mankind. One of the safest drugs known. No harm in trying this for someone as debilitated as someone with long COVID. So next slide. Again, this is another story. I won't keep going, but you guys can read this later. But again, just abrupt and pretty brisk responses after prolonged symptoms and taking ivermectin. Next slide. Same thing. I don't know. I don't want to keep going over all these. I think people either get it or they don't. But let's just look at what she said. 36-year-old woman, miracle. Understating it. I immediately felt better after my first dose. After my second, I felt great. Another dose 2 weeks later. Then I started to feel amazing. And actually, we can talk about this case because this case really made me think. And I'll tell you why. Is that she had Lyme disease in 2016, which effectively disabled her for years. And she was able to get out of the house, but she had a very poor quality of life. So for 2016 to 2019, she was doing really poorly. And then the poor thing, she gets COVID. And she recovered to somewhat normal. She was fatigued on weekends, slept all weekend, and she could only function 1 day a week by August. And so when her story is, she's telling us not only did she recover from her post-COVID, but she felt better than she had since her first illness, which led her into this post-illness syndrome. And so I thought this was as remarkable a story as you're going to hear from a patient. So very cool story, and I'm just happy for her. It really does sound like she got her life back. And so again,
to quickly add, I'm going to mute your mic for a second so this echo is not there. For my own patients as well, or those cool beans who have been listening to my videos about ivermectin, I get so many messages back that I started using ivermectin because I had COVID, but then my pains, my joint pains or my muscle pains or my chronic illness disappeared. And now that I have stopped ivermectin, it is starting to appear. Those previous things are starting to appear again. And what is going on? Should I just continue now? It is acting like magic, even on the previous or earlier or pre-existing conditions as well, which is magical.
Magical is true. It's so cool. One of the nice little anecdotes I got a couple of months ago is, as you may or may not know this, but Paul and I started giving lectures in South Africa. I think he and I probably caused a revolution there because there's so much crazy stuff going on in South Africa around ivermectin. But some of the people who invited us to talk, they started prophylaxing with ivermectin. And one of the guys that I know, he said that his niece, who had terrible chronic skin conditions, she started prophylaxing with ivermectin, and she said that her skin disease completely cleared up and she felt better than she had in years. And so, but that's actually known in the literature that ivermectin can be used. I think it's used for rosacea and some other skin ailments. Anyway, so next slide. So that's my little take. That's my little my 2 cents on long haul COVID. Again, I don't want to sound like Johnny One Note, that the answer to everything is ivermectin. It very well may be the answer to everything, but it's certainly the answer to at least acute prevention, treatment, and even chronic COVID. And so, really, just a terrific drug and we needed one for this disease because this thing is bad. All right, so let's go over some updates. I think there was a momentous occurrence that happened last weekend, and it was what's called the BIRD conference. So it was the British Ivermectin Recommendation Development Panel. It met last week on February 20th. If you go to the next slide. And what happened was this evidence-based medicine consultancy group in the UK, and they've for years done systematic reviews and meta-analyses for the Cochrane Library, for the WHO. They've participated in many, and they've been hired to support and guide the formation of many guidelines over the years for many national and international health agencies. And they just felt that ivermectin needed to be looked at. And so what they did is they coordinated the development of this collaboration of 75 researchers, specialists, generalists, and even patient representatives. They asked for no financial support. Everybody volunteered to participate. And they followed the standard kind of WHO approach to evaluating a drug, its evidence, and formulating a recommendation. And so they followed it to the T. And so they did the group did their systematic review and meta-analysis. And if you go to the next slide, and that was the technical working group of the BIRD conference. And they presented their conclusions, right? So the technical work presented it to all the attendees. You can view it at that YouTube address. The entire conference, about 2.5, 3 hours long. And then the panel of clinicians, specialists, patients, researchers, they did what you normally do when you're assessing whether vet medicine should be adopted and recommended. And so they made assessments, they had a long discussion, and then they took votes on qualities of what are the desirable effects. So is it efficacious? Does it have undesirable effects? What is the certainty of the evidence? What is the values and preferences related to this medicine and therapy? What are the resources involved? Is it equitable? Can it be widely distributed? Is it acceptable and feasible? You guys get, it's a wide-ranging judgment of whether this should be adopted. And if you go to the next slide, this was the forest plot of the meta-analysis, just looking at the outcome of deterioration. So based on all these RCTs, they found a really strong and fairly tight treatment effect for preventing deterioration and for recovery. So that was one conclusion. Next slide, they also did mortality. I might have removed that, but there was a number of forest plots that they did there. But ultimately, the group near unanimously not only recommended ivermectin, they recommended it strongly. And I didn't put in all the recommendations, but if you look at the document, I'm happy to share with you afterwards, and it will be posted on their website within a week. But they also recommended in the prevention, so as a prophylactic agent against COVID, and in all phases of treatment. And so it was a really profound and near unanimous strong recommendation from an international group from all the regions of the world. And I just think that this document, it's being sent to the WHO, it's going to be sent to the NIH, to the FDA, to the Canadians, the Germans, the French. And so because if you look at all those regulatory bodies, they're just they're all negative on ivermectin, but none of them are actually looking deeply into the data as some of us groups have. And so I just thought that was a really tremendous feat, what that group did, what they put together, and the result is truly remarkable. So I think you're the cool beans should know about this. Things are happening, okay? It is going to be the standard of care for the treatment of COVID-19. I will go to my death saying that. Hopefully I won't die before that happens. The only question I have is when will it happen? That's the only thing I can't answer. It will happen. I just don't know when. All right, next slide.
Again, muting you just for 1 second to add my comment here. In the US, Dr. Paul Marik, the momentum that you have started, and then going to South Africa, and then this news going out as well. So again, credit going to Clay's study from Australia, and then Dr. Alam from Bangladesh doing the initial, having the courage to do the initial treatments with this, and then your voice. And now this is spreading, spilling in the world. Even this bird meeting, I believe, is a consequence of what was happening. So here we have Dr. Corey, who is actually one of the leaders for this thing. So thank you very much for doing what you've done. And I'm going to unmute you. My apologies.
No worries. No, thank you. I appreciate that, Dr. Bean. Next slide. So, and these are just some other cool things. So this paper by Juan Chimie, if you guys know who he is, he's been doing these epidemiologic analyses. His paper was finally completed. He got some co-authors. They got some help from some researchers at Emory, and it's a very mature manuscript. It's on preprint. It's been submitted for peer review. I demand that everybody read this paper. If you want to know where the paper is, go to our website. It's on the middle bar. You'll find it. You can download it. Just read the paper. It is in my mind, every public health official in the world should read this paper. It shows definitive proof of natural experiments that have occurred, which shows the eradication of COVID where there's widespread ivermectin distribution. It's happened, and we've seen the effects, and these guys have measured it. They ruled out every confounder. It is an amazing, amazing paper. So I just invite everyone to look at that most recent version. An early version is what converted me, but the most recent one is insane. Next slide. So here's a cool story. So Juan Chimie, who's part of our alliance, so he does all these cool analyses. He's just watching everywhere in the world, wherever ivermectin is being adopted. He's looking at case counts and deaths before and after, and he's just shown, he has so many examples of these tremendous population-wide benefits. And what happened is the most recent conversion was the Mexican Social Security Institute, Instituto Mexican del Seguro Social. And that's kind of their main public health agency. And what they did in Mexico City is they decided to adopt a protocol where in their 250 testing locations in the Mexico City metropolitan area, using rapid tests, if you tested positive, you got ivermectin. And that was their protocol. It started on December 29th. Look at the next slide. So Juan, in late January, he tweeted and he did his first analysis. This is actually was before this, and I didn't include it, I'm sorry. But he did his first analysis somewhere around here, and he said, hey, Mexico adopted this December 29th. Let's see what happens. I'll tweet every week showing you the case counts. And this was hospitalizations. And so you see December 29th, and somewhere right after January, the hospitalizations peak, and then they rapidly decline. A week later, more. 2 weeks later, even more. This is February 23rd. It's almost back to the prior baseline. And so this amazing, really sharp drop in Mexico City of hospitalizations, and then the next slide shows the fatalities, excess fatalities. Same thing, you started to declines more and then declines even more. It's still going. So when you, and this is actually what Dr. Andy Hill, the consultant at WHO, he's been saying this, that his vision of the future is almost modeled after HIV, which is a test and treat protocol. Mexico City is leading the way in that concept. Test and treat. You're positive, boom, take these pills, and then look what happens. Just tremendous results here in Mexico City, and they're starting to really talk about that at the IMSS, and I just wish the rest of the world would listen. I wish everybody could do test and treat. We wouldn't be talking about COVID in about 6 weeks if we did this, if the whole world did this. Anyway, keep going. And then this is my palm to forehead things, just stupid things that I see, misunderstandings about the role of ivermectin, and I find them both comical and just frustrating. But let's go over some of the things that I've seen, which I've almost laughed at. So next slide. So this is the Infectious Disease Society of America, known not so affectionately as the IDSA. So these guys, they did the update to their ivermectin recommendation at the end of January. And in their eminent brilliance, they suggest at the end of January, when Mexico City is basically curing COVID with ivermectin, these guys suggest against ivermectin use outside of the context of a clinical trial. They're going back in time. Not even the NIH is recommending that anymore, right? So, and then what I found just literally comical is that the sentence that I underlined. In addition, there were concerns about publication bias, as the available evidence consisted mostly of positive trials. Now, let's be honest. Publication bias is real, right? We've known for years that the clinicians who do experiments that are positive are much more likely to publish than if you find a negative result. Okay, fair enough. But here's my statement. Do your job. Go assess. There's ways of assessing whether there's publication bias. You look at clinical trials registries. That's the whole purpose of clinical trials registries, is that most journals will not publish a trial unless you registered it first. And it's one of it is for that reason, is so that you can remove publication bias. Guess what? Andy Hill, next slide. Andy Hill of the WHO, he has looked at every clinical trial registry around the world. They have done an assessment. There is no significant risk of publication bias. So this amazing finding of all these positive trials, guess what, Dr. Mobeen? It might be a real finding. Just putting it out there. Could be real. All right, next slide. And I'm coming towards the end. I got a few more funny/stupid observations.
So, sorry, I muted you for one more second. Today we have a technical issue that if we both have the unmuted mic, then there is an echo. But I wanted to comment in here as well. This is something that I have been saying from the very beginning, March, April, that the organizations, bigger organizations, they have resources, they have a duty, they have assumed the leadership, and they are not able to go and look at the evidence, assess it, or as you just said, do your job. Just doing their job will have the right outcome right in front of us. And we did not have to come in and start teaching these things if this was happening at the right areas. And we actually now have to put more energy in it because we are not taken as WHOs or CDCs or FDAs. So we have to push all of this while they could simply spread it out and act on it. So anyways, that's just my quick rant. I'm going to unmute you and mute myself.
Well, I am sorry you just said that, because now I got to give my own rant, further rant, because I find it amazing that you've been saying that since March, because it validates my thoughts. I totally agree with you. They have resources. It's what I call, you have one job. Represent us. Do something for us. I have been in societies of my profession, in the ACCP, American College of Chest Physicians, American Thoracic Society. You know what the dues are every year? It's like $600 or $800. They have a lot of resources. They have foundations. They have grants. They could easily assign experts to do this work. Why does it have to be me, nights, weekends, not sleeping, running around, doing all of this? They could do it, and you're right, they would have more credibility. And the last thing I want to say about that is, when I read these national guideline committees, whether it's from Germany or Canada or even the NIH, and they say there's unclear quality of these trials. We're not so sure about these, and therefore we're not recommending it. I'm like screaming at the paper, why don't you go talk to the investigators? Go validate how they did the trials. Go assess the quality of yourself. Don't just dismiss it because it doesn't look good to you. It's like, do your job. So thank you for mentioning that. And I'm sorry if I'm ranting, but Dr. Mobeen, I don't know if I told you, but I'm originally from New York, and we have opinions and we express them loudly. It's cultural.
So I love it. Thank you very much. And I am going to mute you for one more second and add some more to this rant. I was counting. So I was trying to write a book about COVID as well. And I was looking at my own work and seeing how much work have I done in last 300 days. We have done now about 350 talks. So I wanted to figure out how much is the volume of work. And can you imagine just me alone, one person, with the cool beans here? I have gone over more than 3,000 studies and line by line highlighted, took the content, written it down again, then illustrated it for the cool beans and presented it. Just one person dedicated to this could go over 3,000 studies and do the work. Imagine the organizations with the resources and duty of doing this. If they were sincerely doing it, how much of a difference they would have made.
So that brings to mind, and this is a quote that I came across, and I gave it to Paul because it reminded me of Paul Marek, but it's actually a quote from Galileo, and it applies to you too, Dr. Mobeen. Is Galileo said, "In questions of science, the authority of 1,000 may not exceed the humble and careful reasoning of an individual." You have these massive institutions, and they've gotten so much stuff wrong. But the humble and careful reasoning of an individual, like Paul Marek, he has just done nothing but read. He's ingested, reams of data on COVID, more so than I think those entire institutions combined. And similar with you, your work output here is phenomenal. I wish they could match the work output. If they had 10 Mobeens or 10 Mareks in that place, forget it. We would have solved this months ago. Anyway.
Or a couple of Corys.
I like a couple of soybeans, a king bean, and a poppy bean, and we'll get it taken care of. So anyway, next slide. And then this one is again almost comical. It's almost black humor, but these are two meta-analyses of randomized and observational trials. Actually, the top one is a collection of randomized controlled trials of ivermectin's efficacy in scabies. The outcome is relief of symptoms at 2 weeks. And if you look, it's a pretty strong signal, consistent, favoring ivermectin. Actually, this is backwards. This is actually ivermectin. They flipped this. But you'll see they found a statistically significant benefit for the treatment of scabies. This is in the WHO guideline document, where they recommend globally to treat scabies with ivermectin. WHO, I think this is either 2014 or 2018. I can't remember. So look at this meta-analysis. This is the one for our paper. Now, these are observational trials. These are randomized. This outcome is mortality. It's not relief of itching at 2 weeks. It's mortality. Look at this. Remember, the number 1 means no effect. If it reduction of that outcome. So the risk of dying with ivermectin, and this is the randomized controlled trials, it's like 15 to 20% risk of dying compared to controls. And you have this really unique and reproducible, profound benefit on death in COVID-19. Yet, where is our recommendation for use from the WHO? They did it in scabies, and where are they doing it in WHO? We're still waiting for that recommendation. How much data? What is this definition of sufficient evidence. This almost makes me angry. And so, one of our friends, Chris Martinson of Peak Prosperity, you guys, some of the cool beans, I'm sure, follow him. He's a really brilliant guy. But he made this joke. He said, "Oh yeah, you remember that worldwide pandemic of scabies where it cratered the world and caused economic shutdowns and lockdowns and and the WHO saved us with their recommendation on scabies?" And I said, "Oh yeah, I remember that pandemic." And so we're waiting for them to save us from a similar pandemic with COVID-19. I hope you guys get that really sad joke. Anyway, this is just unconscionable when you look at this slide. Next slide. And then here's just a couple of stories which I just found just too funny. So these journalists are writing, "Wonder why India has these plummeting cases and there's this dramatic fall in virus cases." What I'm sure the cool beans know is ivermectin is widely used in India. Now, the ivory tower folks in the capital, they don't believe it works. It's not on that national federal health guidelines, but the real guys on the front lines, they know it's working. They're using it everywhere. And so if you go to the next slide, this was even a newspaper article in India where they said sales of ivermectin jumped fourfold. So they're using it like crazy in India. But in those two articles, ivermectin was never mentioned once as a possible influence to the plummeting cases. Next slide. This is from Untitled, and if you look, this is 3 states in India. So Uttar Pradesh and Bihar at the top. In northern India, Uttar Pradesh adopted across their whole state ivermectin treatment on August 1st. 234 million people live in Uttar Pradesh. 120 million people live in Bihar. And if you look at their numbers, right? So here you have Kerala in southern India, and they were approximating what it was like in Bihar, and they were a little under what it was like in Uttar Pradesh. And then things started to climb, right? Bihar had a little bump and then it went down, and Uttar Pradesh had a huge bump and then it went down, and now they're similar and they're the lowest in India. Look at Kerala. Insane, going nuts. And so these are huge populations in which ivermectin is ubiquitous, and they're essentially controlling the pandemic. Gee, Dr. Mobeen, I wonder what's causing this ridiculous drop in deaths and case counts in India. Who knows? I wonder what it could be. Go to the next slide. I'll show you what their theories were. This was from the paper. So I'm reading this and I'm just like laughing. It's not that India's testing less or things are going underreported. It's just been rising. And now suddenly it's vanished. I mean, hospital ICU utilization has gone down. Every indicator says the numbers are down. Scientists say it's a mystery. They're probing why India's coronavirus numbers have declined so dramatically and so suddenly in September and October, months before any vaccinations began. Next slide. And this next slide, I'll just go to the bottom one because it just like all their theories of why it should drop just didn't make sense to them. They said it's actually the opposite of what should be happening. And then 3 options. 1, it's gone because of the way people behaved, so we need to continue that behavior. Or it's gone because it's gone for some reason, it's never going to come back. Or it's gone, but we don't know why it's gone, and it may come back. So someday they'll figure it out, Dr. Moby. Maybe they should tune into this program, or you should blast this across India. So anyway, next slide. I think I'm coming towards the end. Oh, let's talk about the U.S. This is pretty cool. Paul saw this article in JAMA showing prescriptions of ivermectin. And so there was a little bump in the summer, but it's been pretty much stable, around 5,000 prescriptions. I think this is per week. And then suddenly, Paul's first lecture of YouTube was early mid-October. We put out iMask late October. My manuscript went on a preprint on November 13th. Right here is when I posted my preprint. And then my Senate testimony was right around here. And then boom, it skyrockets. So lots of people in the U.S., not enough, but many, many people in the U.S. are using ivermectin. Go to the next slide. And this was a table from that same paper. The number, so this was baseline number of prescriptions, and then this was the increase in prescriptions over baseline. And the most increased medicine prescription out of all of them being used was ivermectin. And the peak week was December 18th. And so in the last few months, the U.S., I think a little bit under the table, right? Because it's not officially recommended. The IDSA doesn't want you to use it. The NIH barely wants you to use it. In fact, they didn't change their thing until mid-January. But guess what? It's like a revolution. There's some rebels out there. Some rebel physicians, probably cool beans. Probably it's all driven by cool beans, I bet. And so there are people using their lives being saved. And so and I think I'm done. I think I'm at the end.
So, apologies, I muted you for one more second, and I wanted to give you another anecdote. So, this morning I was speaking with a doctor who practices here. He used ivermectin for the first time for his own family when they became sick with COVID. And what was charming for me to hear, so now he uses it for his patients as well. What was charming for me to hear was he said, you know what, I happened to find iMask Plus protocol, and since then I've been just using that. I used it for my family, and now I'm using it for others as well. So the work that you have done, and Dr. Paul Marik has done, and the voice that you have raised, that has actual measurable response. And I simply believe this. I mean, as much as these are the media is kind of wondering why this happened, imagine if more people were open to it, how much safety we would have brought to humanity, and how much reduction in death and misery would have happened. So, as much as it is kind of weird that these organizations don't understand it, it is actually quite damaging as well that they don't understand it. So, once again, thank you very much for your work. Thank you for Dr. Marik's work. You guys have made a difference for the world.
I appreciate it, Dr. Bean. Next slide. I think I'll just show a couple more about the U.S. Oh, this is our slide. So these are confirmed adoptions by national health ministries. We know that use, especially in the U.S., for instance, is skyrocketing in many places. We're hearing from people all over. But these are the official adoptions countrywide, and they're really increasing. Many of these have been in the last month. And so this is really satisfying. And you know, one day, like I said, this map will be all one color. But right now it's mostly South America, Central America. Mexico's increasing, but South Africa's there. Zimbabwe just ordered a massive importation of ivermectin into Zimbabwe. North Macedonia, God bless Slovakia. They are the renegade state of Europe, right? It's an EU country, and they bucked the Europeans, and they said, we're adopting this. We believe it works. And then obviously there's Uttar Pradesh and Bihar. And so I'm really looking forward to this map colors changing over time as we go forward. Very satisfying. Next slide. And then the U.S., yeah, that's another map. And then this is from the C19 study group. I love that website, that group that, you know, catalogs all the studies on ivermectin. Here they use different colors for like some, mixed, many, and countrywide. And so they're being a little bit more gratuitous to the U.S. I think there's definitely some regions in the U.S., but it needs to be more. Next slide. And then this is just some institutions that have been using it for a while that have adopted it and are already reporting just tremendous results. And then the next slide, this is just a smattering of big facilities, chains, assisted living facilities, or groups of assisted living facilities in multiple regions. We're just hearing more and more reports of adoption amongst hospitals. Again, done independent of the NIH. The NIH refuses to lead here, so there are some physicians and some healthcare systems and hospitals that are filling that void and showing leadership and good judgment. So God bless them. And I think that's it for me. Hey, Dr. Bean, before we go to Q&A, can I get a 30-second rest?
Absolutely. Please do. So, cool beans. I don't know if I accidentally stopped Dr. Corey's camera or he stopped it, but when he comes back, we'll see. How are you guys doing? Yeah, so Luffy is here. Are you comfortable continuing on? We are about 1 hour into it. One request that I will make, I think with this message as well, it is really, really important for us to share it to as many people as we can, to make as many people aware. One, Luffy agrees. One benefit of this discussion is that all the studies are actually seeable. If somebody goes to flccc.net, the studies are actually listed out there. so we can easily see the studies, we can see the results. What did you think? Welcome
I'm
back.
back. I was overheating, and I needed a little restroom break.
Excellent. So what I'm going to do is I'm going to keep myself, I'll ask a question and then mute myself so that this echo does not occur.
Is that your cat?
Yeah, so that is a celebrity cat called Luffy.
Wait, what's the name of your cat?
Luffy, Loofy.
Luffy. Okay.
There is a manga character whose name is Luffy. So he is named, our Luffy is named after that Luffy. Okay, cool. So here is what we'll do, Cool Beans. Let's start having our questions. Dr. Corey, we also have some questions on Twitter as well. Totally up to you to decide how much time you have. But I'm going to start reading some of those questions. And then whenever you say time out, I'm done, that's when we stop. And once again, I really, really want to thank you for the work that you've done and the help you are doing. So I'm going to bring Twitter here.
And real quick, you've done 350 episodes in COVID. And so for me to get tired of questions, it seems like I'm not allowed. I got to keep up with King Bean if I'm going to be a bean. So we'll see.
Awesome. Thank you very much. So starting from here, and what I would try to do is that please feel free to answer any question you like. I usually try to keep the questions focused on the topic so that we do not just go in too many directions. So feel free to pass on any of the questions. So Mark Zapp says, are you treating ICU COVID with melatonin? So is that part of your protocol?
So it absolutely is. If you look at our Math Plus protocol, melatonin is one of the plus medicines. What Mark may not know is there's a body of evidence for melatonin in critical illness predating COVID. Like melatonin is actually a pretty good thing for critical illness anyway. Being critically ill in an ICU is rough. It really messes with circadian rhythms. Sleep is disrupted. And there's actually trials showing reductions of incidence of delirium with melatonin. So that was actually already part of my practice. Again, another thing I learned from the great soybean, Dr. Paul Marek. That was already my practice, but it is in our protocol, and it actually has even more rationale in COVID, right? It has some anti-inflammatory and even antiviral properties. Now, ICU, really, we don't know how much virus replication is going on, probably very little, but we use it. Super safe medicine, and it has multiple rationales for use. So yes, I do use melatonin.
Got it. Thank you very much. And there are so many questions on the live side. I'm going to come there for a second. So, Poppy Bean, the next question for you from Mark Zapp as well. And that is ivermectin vericidal?
So, vericidal. So the way I think of ivermectin and what's in my paper, and we've gone through, so here, let me start differently. The mechanisms of action of ivermectin clearly need more research, and it's going to be, I'm sure if I was like a basic science bench scientist, I would be all over this. I would just be doing this all day long because it's fascinating. But what we know so far, the best theories of its MOA, so mechanism of action, is number one, we believe it binds tightly to the spike protein and prevents entry of the virus. That's why the most profound evidence is actually in prophylaxis. We think it can't bind to the ACE2 receptor and enter the cell. So number one, it's a blocker. Number two, we have a few papers showing that it really disrupts viral replication. So it disrupts the formation of essential structural and non-structural proteins. It actually disrupts the function of RNA polymerase of the virus, so it prevents viral replication. And so it's a blocker, and it stops replication. So it not necessarily kills the virus, although it might, but it prevents replication. Same thing in the end, right? At least the same result.
Got it. So like a very static. So I'm going to go to live side as well. There are so many questions. And Cool Beans, I think we will have to invite Dr. Corey once more because there are tons of questions. So let me go to the live side as well and ask some questions from there.
Dr. Bean, can I mention one more thing if you mute for a second? And I'm going to ask
Absolutely,
a question.
please.
I see Mark Zapp's question here. He says, how else could you achieve in vitro 5,000-fold reduction in virus? Oh, I thought that was a different question. I am sure, I wanted to make sure that we address the following, which is this propagating erroneous theory that ivermectin can't work in COVID because it can't achieve the tissue concentrations from the Cayley-Wagstaff paper. Please tell me, Dr. Mobeen, that you, Soybean, and the Cool Beans have gone over that so I don't have to talk about it. Please tell me that.
We have talked about it, but I would love to hear from you as well.
Okay. First of all, anyone who says don't think about ivermectin, it's nonsense because you cannot achieve what's called the IC50, which is sufficient concentration in the tissues to interrupt or interfere with the virus. Total claptrap. Nonsense. For multiple reasons. Number one, cell culture models in the human body are very different. Right, the durations that you study them in, the dosing frequency, and the fact that we actually have an intact immune system, right? We're not cell cultures, we're actually human beings. That's number one. And there actually has been long known there's very little correlation between a bench study and a human. So the idea that you would take one cell culture study and hold it up as like inalterable or unassailable truth is insane, number one. Number two, is that we have spoken with Cayley and Wagstaff. They have repeated those experiments. The first experiments were in monkey kidney cells. Monkey kidney cells. They repeated those experiments using alveolar cells, actual lung tissue, where we know that the concentration is very high with ivermectin. There's preferential high concentrations. It penetrates lung tissue, and it resides there for a long time. Not only is the concentration higher in those tissues, but their new estimated IC50 is far lower than what is achieved with a single standard dose. So they have disproven that erroneous theory. Now, the challenge is, I think it's their university policy or something, but they don't put the work out on preprint. So this is personal communication that I'm citing. We are dying for them to publish that, to shut up all of those naysayers who are standing on that erroneous theory. So don't believe anyone who starts quoting that stuff at you. The NIH still quotes that, and it's really tiresome. We've explained that to the NIH, and they're still putting that up on their website. It's really aggravating, as you can tell.
Makes sense. Thank you very much. I'm gonna again keep doing this. Yes. So next question, I'm going to go to the live here. One quick comment here. Jenna is a long hauler. She's been using ivermectin for some days now. So she's saying, my hair no longer shedding. Praise the Lord. So very good, Jenna. Good to know. And Jenna is a very good Cool Bean as well. Then there is a question here from April. What is your thoughts on kids doing Mask Plus? My 10 and 12-year-old are 80. I have been on prophylactic ivermectin for 2 months.
So we do not recommend prophylaxis for children. Everything in medicine is always, every time I use any medicine, dose, or decision to treat someone, it's always with a strong assessment, my best assessment of risk-benefit using the data that I have. Even though ivermectin should be considered extremely safe, and it is, and it's probably okay to prophylax, we just don't recommend it. Most kids weather COVID really well. Ivermectin is so effective as a treatment, I would just have it on hand and I would do it just in case, meaning if your kids get sick, put them on ivermectin. But I would not prophylax a child for a long period. We just, and there's even other reasons why I wouldn't, and one of them is supply. If you put the entire population on ivermectin, I think some of the sick will be starved of medicine. So, I hope that's a sufficient answer.
Got it. Thank you.
Treat them when they're sick. Don't prophylax them.
Ivermectin was banned in Philippines. Only veterinary ivermectin is available. Is it safe to take vet ivermectin? I won't be a Cool Bean. I'll be Cool Luffy.
My least favorite question. We cannot recommend animal ivermectin, right? We don't have safety data on it. We have an FAQ, a frequently asked questions on our website, and one of the things we say is we can't recommend it. We don't know that it's safe. It's never been tested in humans, but we haven't heard of any toxicity, and we know that in many countries it's been used. But I'm not going to recommend it. That's all I'm going to say. What I want to do, and if you guys have heard me, know what my work is, I'm about convincing the authorities and getting the healthcare system to make sure that there's sufficient human supply, and I'm not going to rest until that happens.
Awesome. So there's a comment from Jax that every time I look at Dr. Corey, I see Tom Hanks. So that's good.
So I've been told I look like. So when I was younger, a lot of people used to tell me that I look like Roger Daltrey because I had like really flowing locks down here, blonde locks. So if you remember who Roger Daltrey was, right, the lead singer of The Who. And then I used to hear that I was Arnold Schwarzenegger. Some people have said Tom Hanks. I'm a guy who looks like other people. I don't know because a lot of people come up to me. I've been called their friend Jeff. Like I remember when I was in a bar once and two women came up to me and they would not believe that I wasn't their old friend Steve. And they were like, Steve, stop it. And anyway, I could go on for hours. But yeah, Tom Hanks, thank you. I like it. I think Tom is handsome.
So Anthony is a cool bean and he is a long caller as well. Anthony's question is, please discuss the platelet serotonin theory in HC19. Overdose of circulatory serotonin from hyperactive platelets, damaged endothelium can't reuptake as normal.
Oh, I love that one, Anthony. So Anthony Karolakis is a Fareed Jalali bean. You know who Fareed Jalali is, Dr. Mobeen? Right?
Yes,
so
we do.
Fareed, have you ever had Fareed on?
No, we have not, but I have read his work.
Oh, you got to bring him on. That guy's brilliant, number one. So Fareed and I have spoken many times over the pandemic. I have been so fascinated by his insights. In fact, so going back to the question, whatever the question is, the answer is yes. So have I heard of it? Yes. Is serotonin physiology a main driver of what we're observing? Absolutely. Absolutely. In my practice, I've been using cyproheptadine, and I have seen just eye-popping responses. So Fareed is real. His science is real. His clinical reports are real. Cyproheptadine is a true and underused and underutilized therapy. If I could clone myself, I'd have an ivermectin bean. I'd have a serotonin, cyproheptadine, Corey or whatever. But no, I think that's actually a major source of the pathophysiology. The one thing I've been telling Fareed, and he got angry because he's just had such a rough time with the peer review. But I'm like, please, can you publish? Please publish. And the last time I heard, his manuscript, I think, was deep into peer review. But because his observations on Twitter are brilliant, but come on, Twitter doesn't have the reach or the gravitas, or it's not going to sway people. It's going to convert the already converted. But I'll tell you a little anecdote. So when I was learning about serotonin and physiology in COVID-19, I got to understand, there's so much kidney failure that we see in the ICU, and no one's really understood the kidney failure. And when Fareed was telling me that it's probably from renal vasoconstriction, and that's what's causing it, induced by serotonin, I had a patient, a woman in her 60s, severe COVID on 100% high flow, and her kidney function was decreasing day 1, day 2. And then she became anuric. Hadn't peed in 12 hours. And I was talking to Fareed that day, and he said that he'd had really good responses. It was 5 o'clock at night. I went home that night at 7. I put her on cyproheptadine, 6 milligrams, 3 times a day. And I come back in the morning, and there was 800 milliliters of urine in the Foley bag. And I was just shocked. In fact, I took pictures of my EMR, my electronic medical record screen, showing like zero urine, zero urine, zero urine, and then boom, she started to pee. And so I've seen reversals of renal failure, like dramatic reversals, and even I haven't gotten to use it that much lately because we talked about I'm not in the ICU right now. I haven't been in a couple of months, but it'll be a standard part of my practice. Paul has it on our protocol as optional, and I know Paul is using it more regularly. He's in the ICU this week, and he's been using ciprofloxacin. So no, Fareed has really been onto something. I think he's one of the major. I think his contributions to understanding the disease needs to be more broadly recognized, and you should have him on, Dr. Mobeen.
Perfect. So I will have him. I will reach out. Jenna, I was trying to find your question on Twitter, and probably it is difficult for me to go find it. I usually just go one from the next. So please, can you ask that question again? Meanwhile, there is another question here on the live side from Art Patron Forever. Question: any of the bromhexin with ivermectin?
I have not. I will just admit to my large degree of ignorance around bromhexin. We have been studying many therapies. I'm trying to keep up to date on all the trials and studies. Bromhexin is just not in my wheelhouse yet. I mean, there's so many theoretically efficacious medicines, but I am not up on my bromhexin.
Two very interesting questions that I'm seeing. So let me ask you the first one, and then there is another from Jim. So Morris says, why has Merck Pharma denied the effectiveness of ivermectin on COVID-19 when they are the manufacturers?
Okay, so I did an interview with a Japanese television station 2 nights ago, and they asked me the same question, and I gave a really strong answer, and I'm going to give the same answer. So let's be clear on what Merck did. So actually, let me sound balanced first. Merck played a major role in the awarding of the Nobel Prize in Medicine to the discoverers of ivermectin, right? So it's one of their scientists which helped discover how to make ivermectin. Dr. Satoshi Omura is the one who discovered the substance, and it was their collaboration which led to the production of ivermectin. And from its discovery, Merck, this is the old Merck. I want to be clear, Dr. Mobeen, old Merck, not the new Merck. The Merck in the 80s, they decided, they discovered this medicine was so potent against parasitic diseases. They knew half the world couldn't afford this. They knew that most of humanity in those continents were suffering from parasites. They donated hundreds of millions of doses for free. And they eradicated and elevated the public health status of a huge portion of this world. That was 30 years ago. Let's fast forward to 2 weeks ago. The same company puts out a statement in which they said 3 things. They said that their scientists, their panel of scientists, gave no authors, no names, has determined 3 things. Number 1, that they could identify no reason or mechanism for why ivermectin would work in COVID. Number 2, they could identify no meaningful clinical evidence of efficacy. And then number 3, the most laughable and most heinous statement is that they questioned the safety of ivermectin. One of the world's safest drugs for decades, 4 billion doses, and they're questioning the safety. Okay. Those conclusions were given without any supporting evidence analysis or review of or any studies. And those statements are completely unique to almost every other scientific group that has studied ivermectin and COVID. They are totally alone in those opinions, and they did not publish that. They did not defend that. They did not provide any science. So what I'm going to say about their statement is, number 1, there is no scientific basis supporting that statement. That is not a scientific statement. So then you would ask, why would they make that statement? Well, the only other reasons, if it's not scientific, the only other reason that I can identify is that they're financial. And the reason why they're financial is that they have a number of competing molecules in their pipeline in which they've invested hundreds of millions of dollars. They have an oral antiviral agent called molnupiravir, which they're trying to bring through phase 2 and phase 3 trials. If ivermectin is the standard of care, how do you think molnupiravir is going to be doing at $400 a tablet? I really wish you hadn't asked this question because it now makes me look like I'm crazy. But I'm not crazy. I'm not crazy. I think Merck is crazy. And I'm going to finish by saying this, is I think Merck, their action last week, my belief is that that will be a stain on their record for many decades to come. Many decades to come. It was unconscionable, unforgivable, and inexplicable. I cannot believe they did that. In a pandemic, they tried to suppress the efficacy of ivermectin. I don't know, Dr. Mobeen, you want to add to that? You have anything more positive to say than I do?
I cannot be. So these are the kind of things that make me wonder sometimes, and I sometimes discuss this with the cool beans here. I call it an exceptional time, and the actions have to be exceptional as well. What I'm seeing is that these organizations or these medical leadership systems, they are not acting exceptional. They are acting opportunistic. That is where there is failing in our system. I had done a talk where I showed a cute kitten which was all wrapped up in cotton yarn and was all stuck with it. And I had shown that as US, that US has gotten itself stuck because of all of those non-exceptional red tape like things. And now we are stuck with it. Although if you think about it, this kind of a time where the whole world is stuck, and one country that could actually lead it with determination and reliably could be US. And we messed up and we have encountered the biggest damage. And what pains me is there is no one accountable for it.
I think in the reckoning there may be people held accountable, but it'll be too late by then. I don't know. Anyway. All right, maybe a more positive question.
So let's see. There's one more question here. Jim says, do you recommend ivermectin prophylaxis even after vaccination for variants, etc.?
Oh, that's a good question. So the answer would be no. I mean, from what I understand of these, actually, let me say, as of right now, no. But our motto is follow the data, follow the science. If suddenly the data starts to show that these variants are eluding the vaccines and the efficacy is not what they purportedly be, then I think there might be a role for taking ivermectin. But right now, I mean, again, we need more safety data, but the efficacy data seems pretty good. I wouldn't say a vaccinated patient needs to take ivermectin. No, not at all. What we consider ivermectin, we consider it a bridge to vaccination and a safety net for vaccination, meaning safety net for those who can't get a vaccine and safety net if the vaccines don't have that long-standing efficacy that we're all praying that it has. So let's hope that it does and we won't need ivermectin in the future. But what's nice is if they fail or you need these repeated vaccines and there's not enough supply to keep up to date on the vaccine variants, then you're going to have ivermectin to fill in those holes. But as of right now, I would not recommend it.
So there's a question from William Goff. William is also a very good cool bean. So Dr. Bean, Dr. Corey, can you expand upon the proof that there is no publication bias? I believe in ivermectin, but admit 2020 has left me with some trust issues. Your slide has a p-value of 0.934. Good observation.
Can I just say that's really funny? So he's got a p-value of 0.934. He just wants to be reassured. Oh, that is brilliant. That might be my favorite question ever. All right, let me say this. Is going back to my point about clinical trials registries. So if you talk to Dr. Andrew Hill, right, so he is in charge of the team for Unitaid and the World Health Organization. And they actually were hired, his team was hired back in June to look at repurposed drugs. They looked at about 6 molecules throughout the pandemic. And unfortunately, every one of the repurposed drugs they looked at pretty much failed. Either they were negative or they had really mixed results. Nothing had really substance. And what he told me is in late November, someone told him, you got to look at ivermectin and doxycycline. And what happened to him is the same thing that happened to Paul Marek, and then later happened to me after Paul. It happened to Paul first. But he started to see these first few trials, and he was really taken with the size of the signal and the consistency. And since late November, they have done nothing but 24/7 work on ivermectin. And this is what they set out to do. So their job was to scour the entire world's clinical trials registries of every registered randomized controlled trial. They're only looking at randomized controlled trials of ivermectin and COVID-19. And through their exhaustive search, and he has a big team, they identified 56 active trials of ivermectin and COVID-19 that are randomized. And he has maintained contact, he's established contact with every principal investigator. He has not found a trial that was registered and that either didn't recruit. The only ones he found were ones that hadn't recruited yet or hadn't started recruiting. He found none that had been completed and not published. So there's not even one example of an unpublished ivermectin trial. So the p-value of 0.934. Yeah. I guess it's possible that he missed one along the way is all I can say. So there might be like the world's tiniest publication bias happening, and yeah, that's all I can say. But no, there's no evidence of publication bias.
So I had mentioned that cool beans are technically and intellectually quite deep. So there are many YouTube channels that are serving at this time, and they are doing a great job. I think that the cool beans here, what we have developed is a very decent depth of understanding, sometimes even more than the doctors as well. And so that is what you just saw a display of. So one more question here from Bob. Is there a max dose of ivermectin that can be used at one time, or is it solely weight-based without regard to total dose? That is in morbidly obese patients. Thank you for all that you've done.
Yeah, so that's come up because sometimes if you have some heavy folks, you're giving 32 milligrams, and so people give pause. But no, absolutely not. There's not a maximum dose. It is weight-based. There is a high concentration in visceral fat. And so that's why you would need to give a higher dose in a morbidly obese patient to ensure that you're achieving sufficient tissue concentration. So let's say you had a 500-pounder who needed, maybe 42 milligram doses. You would give it to them without hesitation. The second part I would say is that there's numerous studies, or actually one study where they gave healthy volunteers, I think 10 or 100 time doses, all tolerated well, no side effects. And then there's been multiple case reports of overdoses where children took like large amounts of, I think, veterinary ivermectin. Or in cancer, there's been a few case series where they gave 1 mg per kg, and there's been no toxicities associated. So it has a very wide range of therapeutic range, or I should say, safety range or lack of toxicity. So no, weight based, whatever their weight is, you calculate that dose out, and that's what you give.
Patricia says, do you take ivermectin? How long to take it? Tell us, how long would you continue to take it if necessary?
Is that one way to answer the question?
It is the way to answer the question.
So here's my ivermectin. Of course I take ivermectin. I've been taking it for months. I've been taking it since, I don't know, maybe early November. Most of my family, I have 2 brothers, their family, my parents who are in their late 80s, huge network of friends, colleagues. Many of us are on chronic ivermectin. I will say that we've had two people get COVID. One, a colleague of mine, a friend of mine who's a doctor, sees a lot of patients. She was on her second week of prophylaxis and got COVID. And then one of my partners in the FLCCC, Dr. Maduri, I think one of his children or grandchildren was prophylaxing and got COVID. So it's not perfect. I mean, the studies show that it's near perfect, but it's not totally perfect. But I've only heard of one or two that got it while on ivermectin. But yeah, no, I take it, and many of us take it.
Excellent. Thank you very much. So how about we do this? Let's answer a few more questions. And then if you have time, maybe we can meet again this week, next week. And the whole Twitter thread is just sitting idle. And I only asked you two questions from there. This is how important you are. This is how much need the humanity has at this time. So is this okay if we ask you a couple of more questions and then request your time again?
Oh, it totally is. And Dr. Mobeen, you got to understand something. So Paul and I, we are dear friends, colleagues, but we're also rivals. So if I get invited back on Dr. Bean, oh boy, I can tell Soybean, hey, look at Poppy Bean, I'm going back on, and then Soybean's gonna get mad, and you don't understand. We're very jealous of each other. So no, this will be great. I'll come back anytime.
Awesome. That'll be great because soybeans videos have been going in 200,000 views and 300,000 views.
So now I have to beat his number. I'll never beat his number, even though I pretend to compete with him. There's only one soybean. That's for sure.
So let's do this. I'm going to ask a couple of more questions, then we break, and then we'll reach out to you once more, see what is a good time for you, and then we'll invite you once more. So to the cool beans here, I promise you know it that whenever there are Twitter questions, I always go through them, even if it takes many days. So we will go through those questions. My apologies. I think there are too many of them, and there were too many live questions here as well. So I'm going to take a couple of more questions, and then we would request Dr. Corey's time once more. So Jim Miles says, why are you taking ivermectin if you have been vaccinated?
So I haven't been vaccinated. So that's a good question. So yeah, without oversharing, we talked about this earlier, Dr. Bean. I'm unfortunately out of the ICU right now. I am not working for an organization. I do full-time, I'm devoting myself full-time to the FLCCC, which is a lot of advocacy, research, writing. I do interviews and a lot of teaching, things like this. This is what I like to do. So I haven't been treating patients, and so I don't have an employer that's offered me a vaccine or mandated or requested that I get one. So, but I am going to go back, and I'm planning on doing some traveling and working in ICU starting, I think, April. I think the world's problems will be solved by April. That's my prediction. Is once ivermectin is the standard of care worldwide, I think I'm going to go back to my my really true calling, which is to run ICUs. And at that time, I'm sure I'll be offered a vaccine. But right now, I haven't been vaccinated.
So it is so funny that you think about April. I have said a similar message as well, that in next couple of weeks, months, we would actually be out of this situation. So let me ask you one more question. This is actually a very common question, and I think you had a question in a similar gist a few minutes ago as well. How long is it reasonable to stay on ivermectin every other week for long hauling? Is it 1 month, 2 months, continue going? Is there a limit to say don't take more than 10 times? Do you have any guidance there?
So, I will say, so let me start with a general statement about everything, which is, we want to be humble with our expertise. I mean, we study this as much as we can, but we still have pockets of holes where we need data, right? So that's number one. Number two, the question kind of confuses me because it says, how long is it reasonable to stay on every other week? Because they're actually referring to our chronic prophylaxis protocol, but then they use long hauling. So one is a prophylaxis approach, long hauling infers that they're using it for treatment. So if it's how long, let's answer two questions. How long is it reasonable to stay on prophylaxis every other week? I have no data of any long-term adverse effects. I have known now scores of people, maybe 20 to 40 folks, who've been prophylaxing either weekly or every other week since June or July. I know probably 10 to 30 people who've been on prophylaxis longer than we have, without any reports. But that's all anecdotal. I mean, we don't have any really legitimate published data on this. All I have is the idea that ivermectin is really safe. And we have no reports of adverse effects. So I don't know how long, but I can tell you, how about until we get our first reports that there's adverse effects that can be blamed on chronic ivermectin use? And I have not come across that. If you had, let's answer the second question is, let's say you were a long hauler who got benefit from ivermectin but kept relapsing once taken off, and you found that you needed kind of weekly ivermectin to control symptoms. I think it would be, the risk benefit would tell you to keep doing it until such a time where your symptoms don't come back. Is that fair? You understand what I'm saying, Dr. Mobeen? Because the question kind of implies that there's a long hauler there, but I think they're asking about prophylaxis, right?
So you're correct. They are actually asking for the long hauling, but there is an implied question in there, and that is possibly if it did not help that much, and every time they leave it, then the symptoms relapse, as you just said. So could they just keep going with it?
If they get benefit, I would keep doing it. If I found that I felt better on the medicine and felt worse when I was off it, I would take it. Like, listen, so many medicines that we take in the world of medicine are chronic, if not daily, right? So it's almost like if someone said, is it okay to take a statin every day for years? I mean, huge portions of the population take that drug every day for years. And we're talking about ivermectin, right? It's one of the safest drugs. And so, I mean, there's so many drugs that we take chronically. So I think it's a fair question, but the idea that you need to take a medicine for years and not have a problem, that's most medicines that we use, right?
Got it. Thank you. So, two more questions. So this is the second last. Ivermectin, so Nairi is saying that, if I paraphrase the question here, will ivermectin help someone be less contagious?
So again, I'm going to change the question. So let's ask two questions there. So if you have COVID and you take ivermectin, all of the studies show that the time to viral clearance using PCR, which we know is not live virus, but we're finding that PCR negativity occurs much more rapidly if you're treated with ivermectin than not. So if you're treating people with ivermectin, and especially if it becomes the standard of care, I believe on a population-wide basis, transmission rates will rapidly decline. And that's been shown for instance, in Chimie's paper that I brought up earlier. In regions with widespread ivermectin use, you see much less transmission. And I think that's what's driving it. If we ask the question differently, which is, if I take it, will I be less contagious? Well, the answer is obviously yes. All of the studies show if you're on chronic ivermectin, your chances of getting COVID are ridiculously small, not zero. Well, actually, two large trials actually showed 0% chance. But overall, it's somewhere around maybe 0 to 5% chance of getting it. It's akin to the vaccines. So if you don't get it, you're not going to be contagious. So I would say the answer is yes on both of those questions, right?
Let's do one last question. Lena says, do you recommend a particular vaccine? Do you have a preference? How about the J&J vaccine, 1 dose versus the 2 dose?
Oh, so that one's easy. I am not a vaccine expert. I eat, breathe, sleep ivermectin 24 hours a day. So I will not answer. I have no ability to answer. Ask a vaccine specialist. That would be number one. However, I do have a strong opinion on the second part, which is I've read really compelling articles, which brings me back to your kitten analogy, torn up in the yarn, which is scientists and immunologists have looked at the efficacy of one dose versus two dose. And the US strategy, which is insisting on doing two doses for everyone, right? Instead of, how about one dose for twice as many, and then when the supplies get there, then do the two doses? That appears to me to be insanely incorrect reasoning. I don't know if you've talked about this, Dr. Mobine, but many other places in the world have said, of course, let's just start with one dose for all, and then when we get the supplies, we'll go to two doses. So that to me is a no-brainer. Actually, that would require a brain to answer, and it just doesn't appear the brains are operating. Because as I understand it, Dr. Mobine, the current the healthcare authorities are still sticking with that recommendation that they want to go to two-shot vaccinations for all before they start releasing vaccines to the others. I just can we do this? Palm to forehead again. What is your opinion on that?
So I have actually talked about both possibilities. I have talked about it that from a data point of view, the trials showed two doses in a specific structure. So if we wanted to adhere to that kind of an outcome, we should do that. However, from a mechanistic point of view, I've done a discussion that when you take the first dose and the immune system starts responding and becoming trained, then you take some more time and then give the second dose, immune system would boost up. It doesn't matter really 20 days or 30 days. So I have discussed both parts of it so people can make their own opinion.
But I was talking more about on a public health population-wide strategy, not on the immunology of two doses, but when you have, in a time of a scarce supply, do you want to double vaccinate this proportion or single vaccinate this proportion? What's better for the greater society? And my back of the napkin math tells me you should do one dose for the many, and then move to two doses later. But that's just my sense of it. Very compelling arguments to support that, but the U.S. does not want to do that for some reason.
We used to think that we would have enough doses, that we would not have to do these kind of things. So nowadays I've started saying that, yeah, sure, let's stretch it out with one dose because we are falling behind. So one last question, because the previous vaccine question, you did not fully answer that one. So we're going to ask you one more question. So here it is. So Kamran Jamil says, question, I'm taking ivermectin prophylactically. Every time I take it, I feel some pressure in head and face and an uneasy feeling for a day and a half. Is it normal?
So no, that sounds like a reaction to the medicine. Again, it's a very safe medicine. It doesn't mean that you can't have side effects, but this sounds like someone who's having a side effect from the medicine. It sounds like they're kind of willing to tolerate it. I don't know. It sounds like tolerable. Ultimately, I have to leave it to the person who's asking the question. It's everything's risk benefit, right? If it was a severe side effect, obviously you wouldn't take it anymore. If it's mild discomfort and they're really concerned about getting COVID and they're older and have comorbidities where getting COVID would be a very high risk, maybe that's a side effect you want to tolerate. But I can't make those individual decisions. I think that person has to. So it's not normal. It really does sound, if it happens every time let's say he takes it every 2 weeks and for a day and a half he feels kind of off and not right, it sounds like he's not tolerating ivermectin perfectly.
So thank you so much for your presence. Once again, I would repeat this part. You have increased the ambience of Cool Bean Tribe's neighborhoods. So thank you very much for the inciting and enlightening messages. And thank you very much for your time.
Thank you so much, Dr. Mobine. And say good night to all the cool beans. You guys are the coolest of the cool beans. I mean, you guys are great. I really like all your questions, and your fans are terrific. It's really a lovely environment that you have around science, and the way you the way you explain concepts, and I love your little cartoons and drawings and the way you bring science to life. It's lovely. I hope I did. I came close tonight. At least I bring a little bit of humor and reality and bluntness, a little New York attitude to medicine. That's what I bring.
You added a lot. We were actually waiting for you to be here for some weeks now. And so thank you very, very much.
Great. Just tell Paul Marek that I did a better job. You can lie to him. Tell him that you'd rather have me on.
I would send him a note with that message.
Oh, perfect.
Thank you.
All right. Thank you and good night.
Thank you very much.
Yep,
thank you very much for being here. I'm going to request your time once more. Queens, thank you very much. Please like, subscribe, and share. I know it is a long video, but this would save a lot of lives. Thank you.
Anytime. Bye now. Good night.
Bye.